Yeah. So Dr.
I'm
Sharath
ready to go
Reddy
ahead.
is director of Medicover hospitals from Hyderabad, and he is a very prominent cardiologist doing complex interventions. So Impella device comes as the top of that. So let's have his opinion on Impella device.
So thank you, Dr. Ripan, for inviting me to give a talk on high risk angioplasty with hemodynamic support device, that is Impella device. I'm Dr. Sharath, interventional cardiologist from Medicover Hospital, Hyderabad. So let me take you through a couple of cases which I have done without hemodynamic support, and then followed by a couple of cases which we have done with hemodynamic support, which clearly shows the difference what this makes. So this is a case of 45-year-old male had anterior MI with moderate LV dysfunction, was thrombolized outside, and angiogram was done showing two vessel disease, and he came to us for further treatment. So I'll just show you, this is his LV. So there is moderate LV dysfunction, so which is quite clear on this echo. And this is an angiogram which showed total occlusion of right coronary artery, and it's a long segment disease. And yeah, this is a left system. You can see, L6 is more or less fine, and there is a moderate disease in LAD. So it's a kind of intermediate lesion. So, and what we concluded, we thought it's only around 50% lesion in LAD. So we had to handle, right coronary artery chronic total occlusion. So that was our conclusion. So this is an anatomy. You can see it's a long RCA CTO, so which you can clearly see here. So the RCA it's a very long segment CTO, and JCTO of square 2 with an retrograde collateral. So the issues for this patient is basically moderate LV dysfunction and definite reversal disease, CTO of RCA, and most likely I need a retrograde PCI for this case, and also we need guide extensions in such long lesions for externalization. So when such issues are there, see, we did a live inbox recording of this case, so we can see what happened. So uh, I'll just play. Yeah. So if you see here, so we started antegrade. We were antegrade wiring was not successful. Then I went retrograde, and we are about to externalize our retrograde wire. You can see what is happening at that point of time. You just look at pressures here. So pressures will keep dropping. In next couple of minutes. You can see here now it came down to mean pressure came down to 35, 40. So when I was about to externalize, so you can see we started CPR. So and then I had to intubate this patient. You can see we are doing all this stuff. So I had to intubate to complete the procedure. So we completed procedure, but patient went on to ventilator, and the next day we extubated him, and subsequently we discharged patient. But this episode can be prevented if I had an hemodynamic support, at that point of time. So it makes your procedure more predictable, and also, it won't disturb your procedure flow. So I'll show another case which was done outside, not with us. This patient had a triple vessel disease and unprotected LMCA bifurcation disease with a severe LV dysfunction, and also CKD and obstructive lung disease. You can see this is the anatomy. So you can see hardly LV is moving. So there is a diffuse disease in RCA, and there is also disease in PLVB, and this is the left system, which you can clearly appreciate. There is a disease, trifurcation disease from LMCA. So and these are the comorbids. Patient had COPD, CKD, diabetes, and he had a severe LV dysfunction, and there is a complex coronary artery disease in the form of TVD, unprotected left main coronary artery, and calcium, which needs modification, and there is a diffuse disease in vessels, and obviously needs a guide extensions. So they started a procedure, without hemodynamic support. So they did it RCA. So RCA stunting was done. This was done outside. So, and post stunting, and they didn't treat, the distal PL lesion. So that was left. And they tried doing LMCA bifurcation. You can see here they dilated LAD, and subsequently patient became hemodynamically unstable, and you'll witness, they stopped procedure at this juncture. So procedure was stopped. And if you look at this patient, syntax score, it was around 38 or so. And if you look at residual syntax score post procedure, I think it is around 34. So obviously, as patient hemodynamically deteriorated, they stopped procedure in the middle, so leaving your residual syntax score near equivalent to your syntax score. And we can predict the long-term outcomes in these patients. Even short-term outcomes will be very bad. So I'll come to a couple of cases which we have done. So this is a patient of 49-year-old from Kerala, who had a CKD, underwent renal transplant, and again transplant kidney disease. He came for a second renal transplant to us. So in between, he had visits to hospitals where he was diagnosed to have a severe LV dysfunction. An angiogram was done showing triple vessel disease and unprotected left main coronary artery disease. And actually, patient wanted transplant, but because of his heart condition, nobody took him for transplant. With that situation, he came to us. So we evaluated. You can see this is his LV, the poor LV. But yeah, no aortic wall disease. You can see it's a poor LV. This is the angiogram. So right coronary artery is total occlusion, and this is the left system. So left system is, you can see, LM is diseased, and diffuse LAD disease, and also, LCX disease. So if you look at this patient, diabetic, hypothyroid, CKD, and, came for second renal transplant, and there is a severe LV dysfunction, and also he has triple vessel disease, unprotected left main coronary artery disease, diffuse disease, RCS, CTO, may need retrograde, and may need guide extensions, for procedure completion. So this patient going around, because of high risk nature of procedure, no one could attempt, and but he is desperate for his transplant. So we can't do transplant, without treating this. So we had a discussion in heart team about PCI followed by transplant, and bypass followed by transplant, taking the risk of bypass into consideration. So we actually gave two options to the patient, and finally we opted, patient also opted this. So we went ahead and did a PCWP which was high, and then we took Impella CP. See, this is an Impella CP which we positioned, and then we started treating LCX. So we opened LCX total occlusion, and subsequently did an IVAS to understand, stunting strategy, and we stunted, and then we dilated LMCA. You can see what happened, when I dilated LMCA. There is a clear no flow, and you can see the pressure tracing here. So completely, there is no pressure. So it's a ventricular arterial uncoupling. See, for transient period, there was no, LV contraction. So this is the normal pressure wave. And you can see when I dilated the LM, so it's almost gone. So this is ventricular arterial uncoupling, which usually happens when you dilate at LMCA bifurcation, in such patients. And that's a time when your procedure completely goes haywire if you don't have a protected PCI, if you don't have any hemodynamic support. So subsequently, we completed procedure because we had an Impella which maintained its mean pressure. So this is how we did a bifurcation angioplasty. I think mostly we did DKS or so, and then we did LAD. So you can see this is, and then I attempted PCI to RCA. We went retrograde, but unfortunately, I couldn't get an antegrade access because Impella doesn't allow your catheter manipulation so well. So as I couldn't get yeah, RCA antegrade access. See, you can see here, I went retrograde, but I couldn't get an antegrade access. So at that juncture, I had a couple of options. I can do a retrograde knuckling and pull the wire out and complete procedure, but we didn't want to do a subintimal stenting in this patient where we have to do a renal transplant and there is a possibility of antiplatelet discontinuation subsequently. So that's the reason we just stopped there. And yeah, this is a final left system, you can see. So we had a um, really good result. So you can see these are the areas which I have got. So LM 6 mm square and LAD proximal almost 9 mm square, and LMCA is nearly more than 11 mm square and 13 mm squared. So these are the nice areas so which we have got. And then we removed Impella after having a look at his mean arterial pressure after reducing Impella flow to P2. uh, we immediately removed. And this patient, 3 months later, we changed antiplatelets to single antiplatelet. And we also did renal transplant, second renal transplant for this patient. And now he has flown back to his country, UAE, and is doing fine. So another patient, yeah, see, it's a 72-year-old male, diabetic, hypertensive, COPD, OSA, obese individual, and also had COVID recently. And this patient had recurrent episodes of pancreatitis and also acute on CKD, and had recurrent admissions of heart failure, fluid overload, and a couple of times he got even dialyzed. This patient came with an acute onset dyspnea and non-QMI, TROP positive. LV function was good, but there is moderate PAH. So you can see his ECG is fine, and you can see, his LV is also good. You can appreciate here, except for hypertensive heart disease. And see the lesions. There is a diffuse lesion in proximal LCX, and also distal LM is deceased, and there is a lot of calcium sitting in osteoproximal LAD with tight lesions. And yeah, this is a right coronary artery which is near total occlusion. And you can see there is a tram track calcium all over the right coronary artery and also in LAD. So this patient's intact score is very high. And yeah, even CABG risk is very high. You can see the Euro score is 7 and STS score is quite significant. So we had a discussion in heart team between high risk CABG versus protected PCI. You can see these are the comorbids he had: CLD, CKD, COPD, and and it's an unprotected left main disease, calcium, triple vessel disease, needs guide extension. So, and LV is normal. But the problem in this patient is there is every chance he may go, into hemodynamic compromise during procedure, because we have to do a rotablation of right coronary artery, left system. And if this patient gets deteriorated, you may end up in intubation and mechanical ventilation. And of course, and this patient is not a good patient for mechanical ventilation, taking all his comorbids into consideration. So we evaluated for Impella, and we took an Impella. We took an Impella CP. We can even take Impella 2.5 for this patient. And then, yeah, I crossed RCA and we did rotablation. You can see this, yeah. So I did rotablation with 1.25 bar. So, and it's an extensive boring, and patient had episodes of hypertension in between. So, which was countered by Impella. So then, yeah, we dilated RCA, and then, we stunted RCA, and you can see this is the final result of RCA. So we had a good result. So, but it took us almost 2.5 hours, and patient was stable while doing procedure because of Impella. And you can see this is the left system, and we did rota followed by IVL, and then we did bifurcation stunting with DK strategy. You can see, I mean, I want to skip all these steps, so I'll just show you final results. See, this is the initial result, and this is a final result which we have achieved in this patient. But while we were doing bifurcation of LMCA, patient's mean pressure dropped down to 65. So that is because, we had an Impella which increased already his mean pressure to 100. So, and it dropped down to, 65. Had there was no Impella, I think his mean pressure would have dropped to, 40 and 30. That's where we would have ended up in all unpredictable course of,
Dr. Sharath,
procedure.
can we end because your time is over?
Done. So we got good IVAS areas, and then we removed Impella. So to conclude, so patients with poor LV and coronary artery disease with challenging anatomy need revascularization, but not afford or attempted due to high risk nature of procedure. Protected PCI with Impella can be offered to all such patients for stable intraprocedural hemodynamics, allowing uninterrupted procedural flow. And single access high risk PCI also can be used in a suitable patients, where you need a second access. And when you use protected PCI, you can really achieve, very low residual syntax score, which in fact improves long-term outcomes in these patients, which is quite well shown in protected PCI trials. Thank you.
Yeah, a nice talk. I will request Dr. Balbir Singh sir if he has any comment to make on Impella use.
Yeah, Dr. Reddy, excellent presentation, really nice cases, and I really enjoyed the cases, which were very nice. So, what is your selection criteria? The wedge pressure, the hemodynamics, or just the LV ejection fraction? Because it's so difficult sometimes to, or the anatomy, or a combination of all this. So, do you have a scoring system to say that I'm going to use Impella upfront in this patient?
It's a combination of all factors, which we have to choose. If you see the second patient, or the last case which I have shown where I used Impella, that patient LV was normal, but the whole thing was the entire anatomy which I have to handle was too complex, unprotected left main, and almost near total occlusion of RC, and long lesions, diffuse lesions, calcified lesions, and patient had a COPD, CLD, chronic pancreatitis, and is absolutely not fit for any ventilation. So that patient, I don't want patient to go on to ventilator. So because in these cases, if procedure mean pressure drops during procedure, the first thing which happens is, patient will go on to ventilator. So that's the major reason, which we had to shift. So we have to take combination of all hemodynamics and anatomical complexity and comorbids. So taking all the things into consideration, we have to decide, what exactly you want to achieve in that patient. So sometimes patient is already unstable where you are using Impella. Sometimes patient is stable hemodynamically to start with, but you anticipate, unstable hemodynamics during procedure to prevent that, we do it. And coming to the scoring systems, there is one scoring system. It is not yet evaluated, the protected PCI scoring. So in which, there are factors, comorbid factors, hemodynamic factors which are mentioned, and also your anatomical procedural risk. So there are nearly 7 to 10 things. If patient score is more than 4, those are the patients where it's appropriate to use protected PCI. So that scoring system is there, but it is not yet evaluated completely. Yeah.